Sorry, problem. I need to go out and go in again. Okay.
Yeah, okay, we're here. Yeah, reboot. Yeah, sure.
Sorry, problem. I need to go out and go in again.
Yeah,
Okay.
reboot. Okay, we're here. Reboot totally. Yeah, reboot. Yeah, sure.
Sorry, problem.
That's a common thing with computers. If something goes wrong, reboot. First step. You don't have to have a deep understanding of computers, but you have to know what reboot is. That'll get you through a lot of problems. Don't you think so, Mariana? Don't you think so?
I agree with you. I agree 100%. I always do the same thing. It's not working. I just reset and try to discover what was going on instead of like trying to discover what's going on. I just like reset and everything works in the consequence.
Okay, here he is. He's back. Let's see.
Yay.
Okay, Gustavo, let's try it again. Okay, you're sharing now. Okay. Very good. Perfect. Perfect. Oh, we can't hear you, Gustavo. We can't hear you. Gustavo can't hear your audio.
Okay. Okay. Sorry. Can you hear me?
Yes, now we can.
Okay. Thank you. Thank you, everybody. Have a good evening. Thank you, Professor Barba. Thank you, John, for the invitation. And now we're going to talk about epilepsy surgery, general concepts about that. I'm a neurosurgeon here in Curitiba, and I have no conflict of interest. And as we're going to talk about surgery for epilepsy, and of course it's a treatment, we need to know something about the disease. So we're going to see a little introduction and about the surgical management. Well, epilepsy is a disease well known, and there is a hard concept on that today, even on the disease and about the clinical appearance, that is the seizure, but it won't be in that time. Seizure and about epilepsy going to be described about 3,000 years before Christ, and all over the years, everybody is going to study and trying to decipher this disease. And some kind of the history, they already thought there is some kind of sorcery or possession, and on that time they really start to treat it. They treat it initially with the trepanation. Diverse kinds of people in the past use that surgery, especially for possession and something like that, and it was considered the first kind of epilepsy surgery, and is considered the first era of the epilepsy surgery, the trepanation, a cranial surgery, until the 19th century, when they begin to understand really that epilepsy came from the cortical area on the brain, and there is a electrical basis on that. John Hughlin Jackson, as known as the father of the epilepsy, one of them, of course, he's the most famous, but in that time, in the 1860 and the 1886, they start the new era, the modern era of epilepsy surgery, when Sir Victor Horsley in London performed the first epilepsy surgery, it was for depressed skull fracture, and the patients were in a good way. So they changed it for the cranial surgery to a brain surgery, and that's the start of the history of the epilepsy surgery. But we can see that the EEG was discovered by Berger in 1929, almost 50 years after the first surgery. So with the EEG, we can see the patterns, the normal and their variations. And with that, the neurosurgery begins to evolve, begins to grow. And the epilepsy surgery is very linked with the technical evolution. And that's very interesting. In 1929, after the EEG, Penfield and Jasper in Montreal, they just used that new technology to promote some information, technical evolution, and that they used to use the EEG in an intraoperative way, just to try to resect and also to see how was the waves and the EEG, and that was going to evolution. And nowadays we still use something like that for intraoperative electrocorticography in an acute way in the operation room, or just in a chronic way when you need to study the patient for a further posterior resection. So with this, the knowledge of the function anatomy, the neurological function anatomy was so fast in evolution, and also the epilepsy surgery evolution. In the 60s, especially, the temporal lobe was the most important epilepsy surgery and site to understand, because here we have the electric alterations and the clinical symptomatology, and then they start to study in a very profound way the temporal lobe. And so they discovered that there is really a sclerosis in the hippocampus, and that was spread worldwide. So the temporal lobectomy at that time was to be done all over the world, and with a very good results. Also, we have here in Brazil, at that same time, in 1958, Professor Paulo Niemeyer, who described one of the techniques for temporal lobe epilepsy. It's a transcortical way and a selective amygdalohippocamectomy. And that was very used on that time and is still used today. So in the future, they start to grow technology and evolution, and with that, they came with the brain images, first with the tomography, and then with the MRI image, and their evolution also with functional and radiopharmac for brain metabolism. All that armamentarium help us to understand and study the epilepsy and try to help those patients. At that time, when they discovered the image about the brain, there was another revolution, and probably the third era of the epilepsy surgery. The news kind of lesions was discovered, and also start to be treated. The principal cause of the epilepsy surgery on that time was hippocampal sclerosis, and when the MRI came, it was amazing. They could really see on image what they imagined to have it. So it was a big step on the medicine field, and also neurosurgery and epilepsy surgery. Also, with the evolution of the MRI, we could interpret the images and try to find what is that from. And usually the functional MRI is very important because it's a non-invasive exam that can help us to make a brain map and a planning with the surgery. We also have those exams with for brain metabolism that also help us very much in those difficult cases in some refractory epilepsy, and sometimes help us to find where is the epileptic focus, and that is the most important on the diagnosis. So here we are in the 21st century. Nowadays we have the robots also to help us in planning with the implants of some electrodes in the brain, and also to use to treat. Also those temporal sclerosis nowadays in the big service in the US, they're not performing surgery anymore, open surgery. Nah? They are making the laser ablation with the implant most of the time with the robot. So the evolution also trying to help us with the epilepsy. And nowadays, what we know about epilepsy is that it's a chronic neurological disease that is 1% of the world population estimated. It seems to be a small number, but when you have the real number in absolute persons, it comes about 65 to 70 million people around the world with epilepsy. Here in Brazil, we estimate about 2 million people with epilepsy. And besides of those problems, social problems, work problems, school problems about the epilepsy, they have also increased the risk of death. And that's very important to think about their treatment. Epilepsy nowadays, all of us know that is a disease with a clinical diagnosis, and the complementary exams about the image is just to find if there is any possible reversible cause to be treated. Nowadays, every year we have a new medicine being proposed to treat epilepsy, and one of them most expensive than other. And the treatment is the principal goal, to improve the quality of life and to control the seizure. Okay, but it's also known nowadays that 50% of the persons who have epilepsy, they are controlled with one kind of medication. When you add one more medication or two, they just came to 75% of control of the whole population. So we have still 30% of the patients that is resistant to any medicine. So they are called to be drug-resistant epilepsy. And unfortunately, they use a lot of drugs, a lot of medical medicines, and they are not free from seizure. And those patients are the ones who need to be indicated for specialized centers nowadays. They should be studied in an individualized way, and with all the armamentarium that we have today, image, electrophysiological exams, metabolic exams, neuropsychological evolution, and also it need to be the proposal to be studied in the surgical way, especially with intracranial electrodes. All of this to try to focus and to find the epileptogenic zone. The epileptogenic zone is the area where the stimulus of the seizure begins. And that's the way that we should treat. That's the area that should be resected or disconnected, okay? In the way to treat the epilepsy. And this is possible just to be done when you know where the epileptogenic is on. And to know that, you need to be a very intrinsic way to be studied. However, even those 30% of refractory patients, just 30 or 40% of them are candidates for surgery. In the real way, about 10% of the total patients with epilepsy is candidate for surgery. Unfortunately, it's a small portion, but it's a huge number. And it's a small number because even if you are drug resistant, most of the time you don't have the complementary exams all together and in a manner to be certain the surgery. So all of this there's a lot of study and take time, and most of those patients has a treatment delayed. Well, the result depends on the cause and the location of the epileptic focus, and there is a lot of cause that can make epilepsy drug resistant. Okay, the most known is the hippocampal sclerosis, some kind of tumors. With the evolution of the images, we can discover those focal cortical dysplasia, especially in pediatric population. But we can also have some vascular alterations, some post-traumatic, and that's the importance of to be a real study and individualized one. After we have the diagnosis and located the epileptic focus, we need to find and to choose what's the best procedure to be done on that person. We have a lot of kind of procedures in epilepsy treatment. Most of them are considered treatment, is the first one, and those last two are considered to be a palliative procedures, but always is a matter to get a better for the patient. So we're going to talk about the procedures in a brief way. About the lobectomies, it's a classical neurosurgery. You can resect or disconnect a frontal area. It's a frontal lobectomy. The occipitoparietal area in epilepsy surgery, call it in a posterior quadrant epilepsy, and for resection is that the proposal area. And the most known and most considered lobectomy nowadays also is still being the temporal lobectomy for mesial sclerosis. Okay, we can do it in a anterior way with the cortisectomy, and also amygdala hipocampectomy in a sequence, or we can do it just in a selective way, the amygdala hipocampectomy, preserving the cortical area of the temporal lobe. Here, just to illustrate, here and down in the left side, we can see what is the area just must be resected on the left or right side. It depends on each patient. And here exclusively the temporal structure that must be resected, that is the hippocampus and amygdala. Hippocampus, also know, is about this shape of the seahorse, and that's the way that we usually approach to hippocampus. We have another 2 or 3 like the approach, but the most used ones is this in the yellow one, designed by Professor Yarzargil in the 70s. It's a route by the Sylvian Fischer. And we have also the transcortical way, just described by the Brazilian neurosurgeon that we taught in the 58s. That's a direct way. Sometimes we just have a lesion in C, but we need to make a lobectomy to resect all the lesion. And when you have just the lesion, does not compromise the lobe, you can make it as a lesionectomy. And to make a lesionectomy, usually you can do it by any other thing together in the room, in the intraoperative way. But when do you have some kind of tumors or some kind of cortical dysplasia, and you need to be sure that the electric pattern is okay, probably in the intraoperative way, we use the ECOG, the intraoperative electrocardiography, just to do a brain map also, to line the way to resect. And after the resection, we can also redo the ECOG and try to see if the EEG is clean. If it's not, we can also go further for the resection. And for lesionectomy, there's very lot of kind of lesions that can be treated: cavernomas, cortical dysplasia, brain tumor, mets, and something like that, when you do not need to be a big resection. But sometimes we do have hemisphere all dominated by the disease, and we need to resect and disconnect this hemisphere. In the past, they also did the hemispherectomy, and they did see that they have a lot of complications about the removal of the big piece of the brain. So nowadays, most of the service I use it to have the disconnection, complete disconnection of the hemisphere, but it stays on the place, and it's called hemispherotomy. There is a lot of pathologies that can compromise the hemisphere and probably need the hemispherectomy. Those are the most common one, and those most common ones are in the pediatric populations. Now we can talk about the callosotomy. Callosotomy is also known as palliative procedure for epilepsy, because you just made the disconnection between one hemisphere to another without the resection of the epileptogenic zone. So you already know that the patient won't be seizure-free. It won't be treated completely about the seizure, but they can be very good response with medications and severity of the seizure. For the callosotomy, we have classically the anterior callosotomy, and also we can have the posterior in a separate way, or in the surgery, we can try to do it in a all callosotomy complete. Nowadays, we have the proposition to do it in a microsurgical way as a classic one, and some services are starting to do it in an endoscopic way. It's less invasive, and does it have a good outcome also. As a palliative procedure also, very common, we have the VNS, the vagal nerve stimulation, that is always an option for refractory epilepsy. The patient may be unable to be resective, they may be post-operative, they maybe don't want to be operated, and the VNS may be one option, or even the neuromodulation with DBS or other apparatus, but the VNS is also the classic one and the most used. After performing the epilepsy surgery, we have already established the classification for that. The most used one is the angle classification, and we say that is a good outcome when you have angle class 1 and 2. We also nowadays have ILA classification also. It's just a little bit different about the angle. There are more class in the classification, but they are mostly the same. Here in the ILA classification, we have the good outcome as class 1, 2, and 3. It's almost the same as class 1 and 2 of the angle. And also this good outcome, angle 1 or 2 and ILA 1, 2 or 3 is the preferred goal for the surgery. So the surgery and the results are very distinctive in a manner, but in a general and median way, the good results are in about 60 to 70%. They just have some difference about the locations and kind of surgery. The temporal lobectomy or the specific resection of the middle hippocamectomy, they don't have the difference in results, and they do have a good result on 70 to 8% of the patients. For the lesionectomy, we have also a good one results about 70%. Talk about cortical dysplasia is kind of difficult, maybe because it's kind of impossible to see a great difference, most of them in the intraoperative way. In the microscope, you can differentiate about the normal brain and the dysplasia. That's why the image and the electrocorticography can help you. So the results are not so good like temporal or lesionectomy, but it's also expected to have a good outcome. The spherectomy in the pediatric patients are very good and very tolerated, and they have expectation to be 8% of seizure control. The palliative procedures, like we thought, callosotomy and VNS, when you don't have a resection to be done, you may try to have those procedures to reduce the frequency and severity of the seizure, and also to improve quality of life, reduce the rate of sudden death, and to get a cognitive improvement. That's a very used and very good way to help those people that don't have the focal surgery proposed. Thank you for your attention, and I'm disposed here if you have any questions or comments, please. Thank you.
Okay, thank you very much, Doctor. We're kind of winging it as far as the host, Mariana. I'd like to ask Pedro. Pedro, would you step up and host now? Because you have a neurosurgery background. I'm neither a neurosurgeon, and neither is Mariana. So could you please either ask questions and lead the discussion? And thank you, Pedro.
Yeah, sure. Thank you, John. So thank you for the amazing lecture, Dr. Gustavo. And it is really important for us to, to have more contact with epilepsy surgery. In our department, we have, very few procedures because we are short of resources. But it is, is a wonderful tool to have. So I don't know if anyone in the audience have any questions.
Yeah, I have a question. When you say lack of resources, do you mean laser? The laser part of the treatment? Is that the part that's missing? The resources?
No, here in Brazil, we don't have the authorization to use laser, LIT. It's not authorized to use here in this way.
Okay.
And here in Brazil, as in other countries,
resources.
we should have the epilepsy centers. And here at Mackenzie University Hospital, we don't have the epilepsy center already formed. That's why we don't have too much epilepsy surgeon at this hospital.
Okay.
Okay, so we have a question from the audience, from an anonymous attendee. So he's asking, when should we choose palliative epileptic surgery? And what is the main consideration to do the epileptic surgery, or like do or not do or don't do the surgery in general?
Okay. Well, the first of all, the epilepsy surgery should also just be done for refractory or drug-resistant epilepsy. Okay. Most of the epilepsy patients are treated medications and they have good control of the disease. And also they do not have anything to be operated on. To choose to operate or not to operate, you need to be a candidate to that. And to be a candidate, you need to have epileptic focus really determined, and that should be in a resective area. Okay. And if you have a epileptic focus and it's possible to remove it completely with no neurological deficits, you have a good chance to be seizure free, and you should also talk that to patient and probably induce to surgery if it's okay. For a palliative procedure, those patients that have drug-resistant epilepsy but do not have a focal focus to be resected or even to be disconnected, as in hemispherectomy, but they do have a lot of seizure, probably daily, they may be benefit to be a palliative procedure, like a callosotomy, VNS, DBS, or some of that, to help to reduce the seizure and to reduce the risk. But you know that the patient won't be seizure free.
Okay.
You have no sound.
Okay, we didn't catch what you said, Pedro. Could you repeat that, Pedro?
Oh yeah, sorry. So we have another question from the same attendee. He's asking about an early indication of epilepsy surgery in children for structural causes like cortical dysplasia, if this mean better result for the patient in long terms. Like, yeah.
Yes. Like we say in epilepsy surgery, time is brain. Okay. So whenever early you can treat your patient, you should do. A great part of the patients take a lot of years to be studied and to be indicated for the surgery. That's the major problem in epilepsy surgery in general. They take too long time, almost 10 to 15, 20 years to be treated. And if you have a pediatric patient and it's diagnosed with cortical dysplasia, and this cortical dysplasia is in a local that could be resected with minor risks, it could be done. And
Yeah.
we should always think about the pediatric patient, they have their plasticity, okay? The brain plasticity. Sometimes you can resect on the temporal and the left hemisphere, and those functions can be connected to other side of the brain.
Okay. Okay. So I have another question. How do you think the development of new drugs for epilepsy treatment have changed the indications for surgery, or the results like?
In the matter of fact, the medication nowadays does not have too much impact in the surgery, even because the surgery is indicated when you have drug resistant. And we have that great study that guide us that they treat the patient with one medication, 50% was controlled. When you put the second medication, you improved it in 20%, 70% of those patients were controlled. But when you put the third or the fourth medication, the increase in the seizure control was just 3%. So after the second medication, you don't have too much benefit with another medication. So if you have a polypharmacy and you have an image and determined epilepsy focus and is possible to be operated, you should operate. But the operation is never to get free from medications. The operation is to be maybe controlled with the less drug as possible.
Yeah, I think you already answered, the last question. He's asking, after the surgery, should we stop the medication right after the surgery? And if not, when is the best time to stop the medication?
Yeah, we never stop the medication the short term about the surgery, and probably most of the patients won't be medication free. Most of them will be using the medication probably in a less dose, in a less number of medication, but probably they won't be medication free.
Okay, you have, okay, you say that 70% of the patients you can figure out or you can control the seizure. Now, the other 30% that are not refractory or have intractable seizures, how do you work them up? So you try to find the focus, correct, on all the patients that are refractory?
Yes, when the patient is refractory and you do have any image that can be resected, it is on the 10% of the total, the 30-40% of all the refractory one. Mm-hmm. The 60% that is drug resistant and is not candidate to surgery is that because you can't match the electrographic findings, the semiology findings, and the image ones. They don't match it together. So you can't operate if you don't have the certain objective on that. And that the options to do on a palliative way. Those that are not resective patients, they can be tried to be in a palliative way, just to reduce the number and the severity of the seizure, but not probably to be free of them. And they will be still on a lot of medications use. That's the problem. We don't have any results on that.
I can remember my background is in emergency medicine. Matter of fact, right at a hospital back over here. But we would get patients that had good Dilantin levels that were having seizures, and we couldn't figure out what was going on. We thought the patient was not being truthful about the medicines. And so, wait a minute, how come you had a seizure? You're in therapeutic range and stuff. Does that work along with some you just can't figure out?
Yeah, the first thing that starts the seizure in the patient is the stopping using the medication. So when it's epileptic patients and they use the medication and they do have a seizure, the first thing as we a doctor think is they should not be taking the medication as okay. That's the first thing that everybody thinks about. But sometimes they have another problems, some kind of infection, or usually they don't have control with medications also.
Okay, thank you. Okay, very good. Any more questions from anybody? Okay. Well, I'm glad we got that done, Dr. Passos.
Thank you very much. Sorry about the late time.
No, very, very good. Thank you for accommodating us. And thank you, Pedro and Mariana. Thank you.
Thank you, everybody.
Thank you, John. See you.
You can
have a nice time.
Stay here. I'm